Welcome to the Indian Newsling Podcast.
Good afternoon. Today we have the pleasure and honor of having with us in our office, in our studio, Dr. Kanti Patel, one of the icons of New Zealand. Kanti, welcome to our office, and it's a great honor to have you with us.
Thank you.
The objective of our meeting today is to delve into your journey, how you started primary health care, how that journey has been since the time you came to New Zealand and you started. Over to you, Kanti.
Well, thank you very much. I came here in 73.
Yeah.
The reason why I came here is my wife Ranjna is born and bred here, and her family was here. I was born in Kenya, and was there till age 10. And at that stage, there was a lot of political unrest,
Right.
because of the Kenya political reasons. So my parents stayed there, and they sent me to India at the age of 10. So I was with my grandparents, and did my primary schools in Nursery, and did my medicine at Baroda, and came here in 73. When I came here, obviously there was a difficulty in getting a registration because of the foreign graduates, but the things was very good. The dean of the medical school here was very helpful to me. He encouraged me quite a lot.
There was only one school?
At that time, there were two medical schools here, Dunedin and Auckland Medical School. Medical school had just started. I think it was second or third year medical school at that, third year in the medical school. So they were very good. And so I sat some American board examinations and got through. Once I got that American board examination, they mentioned that I can get a registration here and stayed here. If I wouldn't have got it, I could have gone to America,
Right.
because lots of my friends are there in America.
Did you have a British passport or you had
Yes, I had a British passport.
Yeah.
And another person who encouraged me quite a lot in general practice is Dr. Satyanand. He was my mentor. And
You're talking about Mutaya.
yeah, that's good. And
Ponsonby had his clinic, right?
he had a practice in St. Heliers.
St. Helens.
St. Heliers. Initially he started in Ponsonby, but then he had a practice in Glen Innes, sorry. So Glen Innes. And he mentioned to me, the best thing is to go in general practice. And he also encouraged me to go into Otara. So my experience there in Otara was, I was very young, 24 years of age, started practice there. And that's a learning point from my point of view. And I think it was a necessity rather than really you go off with the interest type of a things, because of the social situation was something that line. But that opened up my eyes from the first day onwards. And I could see at that stage in primary care or general practice was something like this. The attitude was like that. Most of the practitioners' attitude was, okay, work for 5-10 years, have a nice boat, have a holiday, have a retirement, and that's it. And everyone was making a very good living out of it and very good lifestyles and everything. But when I went there and I saw a different picture altogether, whatever reason it may be, probably because of our background where I come from, or values in which we brought up, and also there was a necessity. So it's a combination of various factors, and there are certain things always in us. Not just like in Indians, there is something in us.
Yeah.
Whenever there is opportunity given to you, you take it and take it to a second levels. So what I felt that, well, look, we can make some difference here, as long as we can organize ourselves. And it was just what helped me is, let's look at what is the need of patient, not just what is the need of myself.
Just like Ranjna ji was saying, put patients first.
Put patient first. That's very critical. And when we started in the sense that access is just not opening long hours type of a things, but how to go to the patient, how to improve the efficiency. What we did is, in the first 25 years of my, that's where I did a lot of clinical work. In those 25 years, I focus onto the developing an infrastructure.
That's till 98.
Yeah. So what I did is, in that infrastructure, I developed a human resources. It was not just a single doctor practice type of a things. Also the nursing care, the management care, and IT development. We were the first people who developed a clinical records in the country. I put
To computerize everything.
Yeah, computerize everything. So that brought up an efficiency, and we can go anywhere. And as a result of that, I think we had a huge database. Even today, I think we have got a database from more than how many? 30, 40 years, if not more. So you have got family records. So that's where we spend a lot of time into all those infrastructure. Not just the physical infrastructure, long hours. Also, what is the need in primary care? I remember very well, one of my shareholders came to me. He's a chest physician. He said, "Kanti, what the hell are you doing? Why are you thinking about putting a social worker in the practice in primary care at your own cost?" I said, "No, there is a need." So we put up a social worker as well as no extra funding whatsoever. No extra funding.
Salaried person.
Yes, that's a salaried person. So that sorts of thing help. And also what we did, so we did it at that level. Then we develop lots of things in the other needs at a primary care. Because our patient cannot afford to have all this private specialist care. So we have developed a bit of workforce in that line. Because at that time, large number of people, especially from India and Pakistan, Sri Lanka, they were medical graduate, highly qualified, with a specialization, but they went into general practice. So what we did, we tapped with them and used that expertise to provide the care. So they were all full-time employed by our organization.
So you were able to attract fresh graduates.
Yeah, we had, in my practice, when I used to run that practice for nearly 40, 45 years, only once I have paid an agency fee to employ a doctor. The rest is just a word of mouth, and I develop an infrastructure.
People walk in.
People walk in, they come from straight from medical school or from the college, come to us.
So when you created a business model, how conscious was there were poorer sections of the people. I have heard that you used to give even free service to people if they can't afford even $5 for consultation fee. How did this model work, Kanti bhai?
I think it is probably efficiency is very important. And obviously when you have efficiency and you focus the time of your consultation and you develop your records accordingly. So access of just the medical records is quite critical as well as. So what happened by bringing that efficiency, what other people used to take 20, 30 minutes, we used to give it within 5 minutes with a lot of efficiency. Plus also what we developed is, we have a networks of the clinics all over Auckland. So what happening is, we have a records of most of the people, and that helps us quite a lot.
There is a general feeling among people, even we as patients feel. If a GP spends 15 minutes with me, I feel that I have been looked after. If he sends me away in 5 minutes, I feel that does it work in your profession?
Well, it depends upon how you think about it. It's a relationship. Like Ranjna mentioned, that I never had any problems with any age group, any gender, because that's a relationship between you and your client.
Right.
So as soon as the client walks in, before he walks in, if you know all the problems of him, because you have got everything in front of you, the key factors, rather than talk about how do you do, how is your golf and all those sorts of things, if you say that, hi, how is your blood pressure going on? What is the tablets? What's your last blood test results? That's connection, straight away that connection. So what happening, that gives
That's
more
what
confidence.
patients look for.
That's a patient, not 15 minutes. And that's what it is. And the second thing, after consultation, we put up a system. See, if there is any red flag or even a danger flags, there is a communication channel open up straight away with your clients. So those are the things which we do.
So patients with critical need, you were used to be in constant touch with them? Or how?
Then followed by all the
No,
organizations.
what
of the
I mean
system.
by you is that
Initially.
Eastamic Healthcare.
Yes.
Oh, I see. And as you started expanding, were you able to attract the right kind of people?
There is always an issue. The 80-20 rules always applies. Because you don't look at your 20, you always look at your 80. And then you start to look at what is the 20, what are the issues comes up, what is the need. So you work through the need, and then they themselves work it out. And usually we have never had any problems. Actually, and we never had any serious HR issues, no medical counseling.
No, of course
issues.
not. Yeah. That is
just,
known. Yeah. Doctor, in the beginning, you must have made home calls
Oh, that was my asset.
when you started in 73 or prior to that?
No, when I started practice, I did home visits. The home visits usually starts early morning, lunchtime, and evening after the surgery. But home visits was very important to me.
Now it is discouraged, is it?
I have no idea what's happening currently now because I'm now out for last 10 years.
Because we don't find anyone talking about house visits at all, because, and also it's unfortunate that most clinics works at first thing you call your clinic, like call my clinic. If it's an emergency, put the phone down, call 111. Straight away you're discouraged. There is nothing like welcome, absolutely none. So we feel sometimes that primary healthcare, you're paying. It's nothing is free. Of course, you don't pay as much as you pay private. I mean, although you're also private. But the feeling that one gets is that you're not looked after. But how is your business model after you've given up? Have you had a chance to review?
Now, what's happening is, I will just tell you my own story, first of all. So, first 25 years, I focused onto the clinical delivery. Then after that 5 years, I just sat around and just tried to develop a model care. Obviously, by that time, I had a huge staff. I think Rakesh used to tell me we had about 1,000 staff altogether in the group working. So there were a lot of support systems. So in those
that would have been the largest provider.
That was the last provider in the country, yeah. So that 5 years, what I thought I better sit around, look at the restructuring part, look at a model care, and that's where I spend my time onto it. Then followed by next 5 years, that was an exit plan. And when there was an exit plan, it was a difficult situation, obviously, because the business was too big from our point of view. So we have to make some critical decisions on that line. And like any other businesses, when you have working with the shareholders or when you have a total majority shareholding given to you, you just take it. And plus also from my point of view, by that time, I was about 65, 70 onwards, so I have my different way of my thinking, my way of life is different, and I have to let go. So those are the things.
So first 25 years you built the practice, then 5 years you restructured, and 5 years you looked at the exit plan. And you are happy the way things have gone in, doctor, or do you think you could have done something different?
Well, there is always something we always feel that we could have done a bit better. And that's where I thought that my model care, which I was thinking to develop, could made a lot of difference. But unfortunately, I could not do that. For one reason or another reason, I could not do that. But that's part of a life. And once you get after a certain age, you have to let
No, but you have left a legacy in this country of building a primary care entity which has touched the lives of
so many
millions of people, which I think is because what at the end of the day, if you're not healthy, there's nothing else that you can do in life if you can't have a healthy life. On that score, doctor, I think you've done extremely well, and I'm sure we will have more opportunities to talk to you. I want to talk to you more about how the business developed and what kind of reaction you had. I suppose we'll do that on another occasion. Thank you very much for being with us this afternoon, and we look forward to people listening to you and also reading the story and get inspired. That is one of the objectives of this. Thank you, doctor.
Thank you for listening to the Indian Newslink podcast.